Before I introduce them, let me just say how timely today is. I don't know how many of you read Le Devoir before the sun rises in the morning, but mine is on my doorstep very early, and I read it. And lo and behold, I opened, and I think it was page 3, in the first section today, 2 articles, and there's a whole page of the Devoir here, a copy of the Devoir, so I want to see it. And these are 2 articles that I think provide bookends for what was going to happen today, where the question that the panelists have been given have to do with how their take on the issue in Quebec, where there is public funding for in vitro fertilization. So the first one that got actually the larger headlines was that a physician from the United States is planning to profit from the reimbursement for in vitro fertilization in Quebec by opening up his company, which does high-tech pre-implantation genetic diagnoses, which are diagnoses made on the embryo while it's still out there after in vitro fertilization, but has not been put into a woman, excuse me. And he's planning to open this. Right now, women who seek this are very often having their embryos sent to the United States and paying several thousands of dollars to have this done. So he's planning to open this, I didn't make this up, to profit from what it says. The next article underneath it with slightly smaller headlines, but I think is the other bookend, and it should be equally forceful, is that the Canadians are finding it increasingly difficult to get the primary care that they need to see a doctor. And that when they see a doctor, if they can get to see a doctor, they're not seeing a physician sufficiently for lengths of time to be able to prise en charge, to take their own health in their own hands. And so I think these are 2 interesting things when we think about what public funding for a service such as in vitro fertilization is all about. So that's my little spiel, and I will have other things to say if they need to be said, but I think the panelists will say it. The order has been determined by the speakers, and so I will tell you who they are. I'm going to give you very brief introductions, because I was told just to read what their titles are, but I have a few more details if you want them. And the order will be Dr. Dahan, who's sitting in the center, Professor Deonandan, who's sitting next to him, Professor Whitley, who's sitting at this end, and then Professor Campbell, who's next to the end on the other side, and then Professor Ells, who's there. Dr. Dahan is with the McGill Reproductive Center. He is trained in reproductive endocrinology and has expertise in many of the areas that underlie all of the processes that you're going to be hearing about today. And I think he will be able to explain them to you, what he does and how he has gotten around, how he comes to do them. He's one of the few on the panel who I haven't met before, so if I'm more formal about how I less formal about the others is because I've known them for a long time. We go back, or at least fair. Ray Deonandan is someone who has worked actually at the Assisted Reproductive Agency of Canada. Some of you may not realize that it exists, but millions of your tax dollars are paying for what has now been a completely denuded, basically, agency, which has had the rugs cut under it, and what it can do remains to be seen. He is also a published journalist, novelist. He is a professor at the University of Ottawa, as well as his other writing skills. Professor Whitley, sorry about that, is a professor in the Department of Psychiatry who's been interested in issues having to do with social cultural matters, the family. He's also trained in theology, I understand, or has in theology, and has worked in the areas of mental health, family, and social cultural issues in psychiatry. Is that fair enough? Okay. And I'm not making this up, I'm just trying to improvise quickly. Next is Professor Angela Campbell, who is a professor in the Faculty of Law. She is director of the McGill Institute of Comparative Law. She, with Lara Corey, has set up the working group on health law and has touched on many of the issues that will be dealt with today, as well as other issues having to do with family relationships and the way families are seen, both within the law and in social context as well. And then we have Professor Carolyn Ells, who's with the Biomedical Ethics Unit, who is trained in philosophy and bioethics, who has spent a lot of time as a clinical bioethicist in the hospitals in Montreal, who chairs the Ethical Review Board at the Jewish General Hospital, and whose main area of interest these days is in research ethics per se. And I think research ethics certainly comes into play here as well. She is one of the conveners of the upcoming International Conference of the Feminist Bioethics Organization, and she has long been on the editorial board of the Journal for Feminist Bioethics. So that's who you are. I raced through that fast. I'm sorry for anything I left out.
I want to thank the organizers and the audience for allowing me to speak today. I'm a reproductive endocrinologist, an infertility doctor essentially, and infertility is when a couple has been trying to conceive for a period of a year. Essentially, it means not having used birth control for a year and having regular unprotected intercourse. And really, when you think about Quebec and reproductive endocrinology, the status quo now is we've had funding for this for 1 year where the government has covered this treatment. And that's sort of what I wanted to talk about for my 5 minutes. And there's some good things about this and perhaps some not so significant or not good things. I think on the pros side, clearly it increases births. And those individuals who are created from those births give a long-term benefit to the society in many ways, through paying taxes, through contributing to society. Infertility has a very significant psychological impact on a couple, which we know. And one of the things the Quebec government did is it limited the number of embryos that we can put back when they offered to pay for this. And I will go over that a little bit, but it controls the number of multiple pregnancies we have, which is one of the complications in infertility. This also limits fertility tourism in some ways, and essentially it's become a free program to the government, and I'm going to explain that. There is, although, nevertheless, some cost to the treatment, which I'll explain as well. It's not a life-threatening thing. It's a question whether really infertility care is crucial medical care, but I think we can make an argument that it is, and perhaps an argument that it isn't. And then there's always the issue that fertility patients, whether they get pregnant on their own or with treatment, have a higher rate of complications in those pregnancies. So we do not have to acknowledge we're going to get people pregnant who are more likely to have some difficulty and then in some ways draw on our medical system. Well, what's been happening? Well, we know that the birth rate in Canada and Quebec in particular has really fallen significantly under the point at which we can maintain our present society. This has occurred as well in the US and Canada, but Quebec, which is the darkest blue line at the bottom, has the lowest rate. However, in 2008, there was a significant increase, and there has been for about the last 5 years, in births in Quebec. And the fertility rate for Quebec women has gone up to about 1.74 children per woman. And that's really the highest since 1976. However, that's not enough to maintain the population. It takes 2.1 kids per couple or per woman to maintain the population. So that's still a little bit of an issue. The age of motherhood in Canada has been going up. It's jumped to 29 years from 27 years. And it's for the first time, women aged 30 to 34, older women, have surpassed younger women in having their first birth. What does this mean? Well, we know that age is a big factor in fertility. In fact, once you hit 30 to 34, 1 in 7 couples have infertility, when traditionally it's 1 in 10, 10% of the population. And as you get older, again, that becomes much more significant. As well, the miscarriage rates go up as people get older. Once you hit 30, there's a significant increase in miscarriage rates, which goes up through a woman into her 40s. What about the psychological impact of infertility? Well, really, it's a loss of control over one's life. This is felt to be something that people can control. I want to get pregnant, I should get pregnant. But again, 10% of population has infertility. And when a couple has infertility, it's been shown that this becomes the focal point of daily discussions, that really they cannot do anything else except for trying to get pregnant. It sort of controls their life. Infertile couples are more likely to have depression, interpersonal dysfunction, and stress in their lives than non-infertile couples. Well, what about the neonatal intensive care units? It was estimated before the Quebec government covered infertility care, because we were putting back more embryos, that 2/3 to 3/4 of babies in the NICU were produced from fertility care. So really, we were doing that. And the NICU is incredibly expensive. It is very, very expensive to take care of a child in the NICU. But nevertheless, the Quebec government estimated it could decrease the multiple pregnancy rate to under 10%. Then the NICU, the savings in the NICU, would cover the entire cost of their program. And to be honest, it has worked great. We're going to explain that in a minute. Even in other places, in the United States, where they have mandated coverage and do not control the number of embryos that are put back, we have significantly lower multiple birth rates and twin rates when the government starts to cover fertility care without controlling the number of embryos. And that's because the couples become more comfortable. They don't feel that this is their full investment. They get one shot and they've got to get pregnant now when the government is contributing to that. Well, the Quebec government mandated embryo transfers to the following. In women under the age of 37, they got one good embryo, if it was a good quality embryo. And if there were poor quality embryos or they had multiple failures of one, they could have two. In 37 years old or more, they get one good quality embryo, again, but they can go up to 3 embryos if there's justification, meaning poor quality embryos, less likely to have pregnancies with poor quality embryos, or multiple failures. And how well has this worked? Well, we just found out from the CFAS, the Canadian Fertility and Andrology Society, which is having its meeting right now in Toronto, that in fact, because of what we've done in Quebec, we have dropped the twin birth rate over the first 4 months, because the first 4 months are the first set of deliveries that have occurred since our program, right? That's because pregnancies last 9 months, and our program's been in place for a year, so we're seeing the first 4 months of this. We have dropped the multiple pregnancy rate in all of Canada by 5%, just by what's occurring in Quebec. That's how significant the drop of multiples we had. And in fact, the multiple pregnancy in Quebec rate due to infertility care has gone to 3%. So essentially, the entire program is just a savings, right? They've moved the money that was going to the NICU into fertility care. So it's really been essentially free to the government. So we have a 3% pregnancy rate, and this has resulted in the program being free. What would happen? Could they just mandate the number of embryos we transfer without funding? Well, let's think about this, because right, the patients still have that stress. They have to pay for their care. What would they do? Well, realistically, I think they're going to drive an hour and a half to Vermont, or they're going to drive to Ontario, someplace that they're not going to be limited to the number of embryos they can put back. Cost of the treatment's exactly the same. And they're going to do their treatment there with the realization that their pregnancy rate will be much higher if they put back 2 embryos, or more if they're older, than if they put back 1. Thank you.
Thank you very much. That was efficient. We didn't even have to wave a white card at you for a penalty time. Thanks very much. The next speaker now is Deonandan. Thank you.
I feel bad I haven't got a PowerPoint presentation. I've been shown up by the physician. Damn you. So first of all, thank you to the organizers for inviting me here. Let me tell you, this is a really fancy shindig you got going on. I'm at the University of Ottawa. We have nothing resembling this. This is quite lovely. Now, I'm going to present to you some of the issues regarding the question we were told to answer. The question we were told to answer, if you're not aware, was Quebec has instituted this funding program. What are the implications? So I'll give you what I consider to be some of the implications from my profession's point of view. I'm an epidemiologist, but I will shy away from giving you my personal opinion on things. However, I will tell you that as a good socialist, I think everything should be free, but that's neither here nor there. So I just came from the conference that Dr. Dahan was talking about, the Canadian Fertility and Andrology Society in Toronto, and let me tell you, it's an expensive, rich thing. Perhaps the physicians don't see it, but we poor PhDs see the money. And they got good giveaways. I got the sperm pen. See this? Little sperm. Right? And Dr. Lippman was saying that there was an ethics session there, but I didn't see an ethics session, which to me sort of rang some bells there. There's lots of sessions on the technology, on the business modeling, nothing on the ethics or social implications, etc. As well, there was a woman who approached me and asked me, so, you know, which IVF clinic do you work for? I said, no, I'm an epidemiologist. I look at the outcomes and some of the ethics. And she backed away slowly and didn't say another word to me. It was a bit telling. I also got to play with something called the intracytoplasmic sperm injection machine, which is my new nickname for myself, this sperm injection machine. Talk about that later. So, what I learned from CFAS, the exhibitors hall, was filled with money-making enterprises, which reminded me this is a billion-dollar, multi-billion-dollar industry worldwide. It's a global phenomenon. My specialty is in reproductive tourism, which is the movement of people across borders to seek these services. And it was interesting to me that none of the exhibitors could answer my globally contexted questions, but they're very focused on the business modeling, et cetera. But keep that in mind, that we're talking about a lot of money here. So, to back up a bit, ideally, when we're talking about this issue, and traditionally we've always tended to frame it as a dialectic between rights versus luxuries. Is reproduction a right? Right? If it's a right, then things kind of fall into place. If it's a right, then the state doesn't have to give it to us, it has to remove barriers to accessing it. If it's a right, that means we can argue for things like human rights and so forth. If it's a luxury, then why are we funding something that's, you know, someone's luxurious plaything, etc.? On the other hand, if it's a right, then we open the door to other kinds of conceptualization, which is important. Often we forget to talk about the same-sex coupling issues regarding this technology. It's possible to be sociologically or socially infertile, not just biologically infertile. So a same-sex couple needs a technology to produce offspring. If it's a right, then we're saying that if we don't fund, then amongst the infertile, only the rich can reproduce. That's the argument traditionally. I would like to introduce 4 new elements into that argument. It's not just about rights. It's about economics, demographics, something about social impact, and something about ethics. I'm not going to touch the social impact and ethics. I think we have other individuals here who will deal with that. So I'll try to touch a bit about the economics and the demographics if I can. Dr. Dahan has already told us, rightly so, that part of the rationale for the province of Quebec funding 1 to 3 cycles is to reduce the number of multiple embryo transfers, which is a fine goal to have, because frankly he's correct. The drain on the NICU system is economically tangible. Previous to this kind of funding, NICU usage levels were going up in many jurisdictions around the world, despite an aging population that we think is due directly to assisted reproduction, et cetera. I'd like to add, though, that this kind of fungibility really constitutes a subsidy to an industry, doesn't it? So we are, in many ways, giving a leg up to an otherwise capitalistic environment. You could say that it's a purely capitalistic environment, but isn't. The government stepping in to give it some advantage. And thirdly, I think there's something to be said here for artificially creating a domestic reproductive tourism market. If you're investing as a state in the further enhancement and development of Quebec's reproductive tourism industry, then it's being done so at a rate faster than the rest of the country, presumably. And if so, then we're creating a gradient of technology and access throughout the country, and maybe that's part of the motivation. So again, my goal here is not to pass judgment yet. It's simply to present some of the possible motivations that could be in play. Which brings me to a public health motivation. There are several public health aspects to assisted reproduction that we need to sort of remember. An important one that Dr. Dahan talked about was the tendency for assisted reproduction to produce multiple pregnancies and multiple births, which is not a good thing. We don't want that. And with multiple pregnancies, multiple births come often low birth weight babies, which is also not a good thing. So we want to reduce that sort of impact. There's a whole host of other possible impacts. The social impacts on the couples, as Dr. Dahan talked about. Also, there's some evidence in animal models that there may be some sort of cognitive deficit depending on the technology you use on the resulting child, et cetera. The risk of consanguinity, what does that mean? If we have sperm or egg donations, by the way, in Canada, do you know how many altruistic sperm donors there are in Canada? Anyone know? It's like 44, something like that. At one point, there were 12. I think I met all of them. I didn't shake their hands, though, because that would be gross. But as a result of having so few, there's a risk of consanguinity, meaning you can produce half-siblings in clusters who don't know they're half-siblings and who are having fun and doing things that may gross you out. So these are genuine public health interests and issues that, again, society has to take note of. And lastly, I would point out repro-tourism, reproductive tourism, which is my field. As the global industry evolves, there is a tendency now to produce and to invest in these kinds of technologies in certain jurisdictions that will draw individuals of high income to them. So I deal mostly with individuals in India who are offering surrogate motherhood services to wealthy foreigners. And that has with it a whole host of interesting technological and ethical issues. Lastly, this issue of demographics, which is a touchy thing to bring up. There is whisperings in some places that the motivations for some of these investments by jurisdictions has something to do with the kinds of people you want to produce. Israel, for example, is known as one of the great Wild West locations for assisted reproduction, and some would suggest that it's because of the need to sort of bolster the production of some kinds of demographically interesting individuals versus some other kinds of demographic. I won't say outright what I'm talking about. I think you can read between the lines. And maybe that's happening elsewhere as well. So my goal here is just to present some of the things that are whispered about in various corridors and to let you draw the conclusions. So I'm going to back away slowly now. Okay, bye.
It's amazing how people can pack so much into 5 minutes. Thanks very much to the two of you. Dr. Whitley, it's your turn. Whitley, it's your turn now. Whitley.
Well, first of all, I'd like to say thank you for the invitation. I think that's a hard act to follow, your presentation, but I'll try my best. I myself am a sociologist, so what I'm going to talk about today is more a sociological interpretation of assisted reproductive technology, and I'm going to try and discuss the short, medium, and long-term effects of ART and what might be happening. But I must say, I must bring in a big caveat, which is that we don't really know, and so as empiricists, as people who do empirical research, we generally don't comment on things until we've conducted research studies and rigorous ones and a number of research studies. And these just haven't been conducted from a sociological perspective. And myself and my colleague here, Phyllis Zelkowitz, are currently doing a study of assisted reproductive technology from a sociological perspective or psychosocial perspective. So I'd really say kind of watch this space if you really want to know the real implications of ART on kind of short and medium-term effects. So I've got a few points in 5 minutes. You don't have a huge amount of time, so I've got 3 or 4 points that I would just like to get over to you. The first one is, I think we should always be careful in social science about choice of words, how we use words to describe things. So we all know when people use the word collateral damage in military terms, that actually means killing human beings. We talk about assisted reproductive technology, and we use this word technology, and the way sometimes you read about this or people talk about it is as if you're choosing between a BlackBerry or an iPhone. What is the best phone? And we talk about technology, but we forget we're actually dealing in human lives here. The human lives of women, men, children, the next generation. And I think this can be lost sometimes, and that's the beauty of sociology, that we can bring in that social dimension and that human dimension to see really how ART is impacting people, couples, fathers, mothers, childless people, grandparents, and society as a whole. And we should really always bear that in mind. The second point I'd like to say is that we should be careful in our choice of words. We should also be careful in our choice of subjects. So we were sent a email by the organizers of the conference that said we should discuss ART because it has a great impact on various factors. And one of the factors it says was the health of women. Now this is true, but ART also has a big impact and is very highly affected by the health of men. And this is often overlooked in discussions of ART. It's often portrayed as a woman's problem, when in fact a substantial proportion of cases of infertility can be attributed to the male. So semen count, for example, diminishes over time. It gets lower as people get older. There's also links to diseases when in men who have children at an older age, for example, the risk of schizophrenia is higher amongst children of people whose fathers were older when they were born. So a huge amount of infertility is on the male, but this is often lost in the debates, and it's seen as a woman's problem, and this is not the case. It's often a problem of men or women. The third point I'd like to make is that when we talk about these things, and here I'm going to sound a bit airy-fairy, but from my previous research experience, I think this is very important. The departure point for these discussions should really be one of compassion. What I mean by this is if we look sociologically over time, there's always been a group of women who have been the target of opprobrium for their fertility choices. If you look at Victorian novels, for example, childless women were often stigmatized as Fielding calls them mules, or as people who are worthless, and what's wrong with them, they've got a problem. And if we look in the last few decades, for example, teenage mothers were stigmatized as people who were loose women sexually and were not thinking properly and blah, blah. And if you look at the media, and we have a study at the moment looking at media, and if you look at random social media, things like YouTube or cbc.ca, you can comment on their stories at the bottom. When this policy was introduced a year ago, there was a lot of very offensive remarks targeted at women and men, and it was mostly at women, even though men are equally important partners, about their fertility choices, that they shouldn't have waited this long, what do they expect, that a lot of money that's going into fertility treatment should be going into cancer research, etc. And I just think we should be aware of this historical trend to always have a group of women who are targeted as being another, or as being less human than other people, as being a target of opprobrium. The fourth point I would like to make is that research is just very important, and I'm kind of reiterating what I said at the beginning, is that we need research on the health effects of assisted reproductive technology, and my colleague here made a very good presentation talking about this, and also the social effects, and both in the kind of long and medium term. What does it mean if there'll be a generation of children whose parents conceive them in their mid-late 30s, and then as the parents are going into retirement, the children are going into adolescence. And that results in what's been known as a sandwich generation, that you then have a group of people who are having children at the same time as their own parents are getting old and having diseases of aging. So you have dual carers, people in their 30s or 40s have to care for young children as well as care for their elderly parents. And when fertility timing was in a shorter period, this wasn't a problem that was so manifest. And my final point really is just sociologically, we have a term called generativity, which means how do you generate yourself to the future? What's your legacy when you die or when you progress through life? What do you leave behind you? And some research has shown that this generativity has now been become very focused on children and childbearing, having a child. But there's many ways that you can be generative. You can, through your work, through your vocation, through teaching, through research, through being involved in a charity and a religious organization. And I think we should also be aware that people who undergo assisted reproductive technology, when all is said and done, and if people have been through many cycles, you'll still get 40 or 50% of people who can't have children. And it's important sociologically that we don't give those people the message that they're not contributing to society, that they don't have a legacy, that their generativity is somehow less than those people who have children. So I think that's my main point, and obviously any questions or comments afterwards, feel free.
Okay, I know who you are, so I can do it fast. I can improvise on that one. Thanks very much. The next speaker will be Professor Carolyn Ells, and you got your 5 to 6.
The philosopher in me and the ethicist in me hits too many buttons. First, I'm not one for technology, actually. The philosopher in me and the ethicist in me wants to go to what's our chief or our main moral motivation for grappling with infertility. I take it that the main moral motivation for developing, pursuing, providing, funding assisted reproduction is in fact that profound suffering that some people experience with infertility. So it's been the challenge of infertility and the emotional effect, social effect it has on people moves us morally. If that's the case, if ethically and morally we're moved in a major way by the suffering of infertility, then infertility is the problem. What's the cure, or what's the resolution? That's actually a big challenge in the philosophical literature on assisted reproduction, is what should be our response to infertility. Is the cure a genetically related child? Is it a child? Is it a parenting opportunity? Is the resolution, or ought the resolution to be fixing the physical problem that prevents a pregnancy leading to a live birth? Should it be the preventing and minimizing risk factors of infertility? For sure, there's a lot of documentation that a lot of the risk factors for infertility are preventable. Should that be our response morally to the issue of suffering around infertility? And also, might it be that we do something to change our social context or our social situation so that people can pursue different goals relating to reproduction? Of course, it could be many sub-aspects of those. But to problematize just what ought we to do if fertility and infertility in particular is what moves us, is the way a philosopher would typically start. Well, without answering those questions or resolving that, for sure it's the case that here we are. We have IVF available in our communities. We have children who've been around a number of years with IVF and related assisted reproduction. Already, for sure, we can say that it has changed what it means to be infertile. What it means to be infertile has changed since IVF has come along. So this also affects how we will respond to infertility. Some of the ethics questions we might ask then are, should we use this technology? It exists, should we use it? Why do we want to use it? Whose interests are being served by using it? Whose interests are being harmed by using it? How will using IVF or the broader range of assisted reproductive technologies affect individuals, affect our society? We can, here in Quebec, getting to the question about public funding, we can insert public funding into all those questions. Why should we publicly fund this technology? Why? Who should publicly fund it for whose interests might be harmed by publicly funding it, etc. The question of public funding, if it comes to me to think about, I want to first think about what's the mandate of that funder. What's the relevant policies, laws, values, and it's quite relevant to say sort of social and political issues that it's trying to address. Does it fall under the mandate of the public funder? And for sure, we also are probably aware through legal cases and others that that alone is a big challenge. Should it be the role of a government to fund IVF? And of course, we've heard arguments both ways, so it's none of these questions are easily solved, but they're the right questions to be thinking about. If people have infertility issues that they want to make a claim on, going to sort of political philosophy language, is it a positive or a negative claim they might make? Is it a positive or negative liberty? That means, is it something that the choice to reproduce or the desire to access IVF technologies to reproduce, is that something that we shouldn't interfere with? If people can fund it, find the means on their own to do it, we don't interfere. Is it, that would be a negative freedom or a negative claim to not be interfered with? Could it also be considered a positive claim that we can make upon the funder of our health resources or our social resources? So that is, we ought to pay for it for good and sufficient reason and make it available. Does the government act or not? I wasn't watching my clock, but I don't have anything. Oh, I'm nearly there. So there's a lot one could say, but I want to just lay out some of this framework. And I think we also realized right from the get-go with our first presentation that the Quebec government in funding set some parameters and some scope to the funding. So another approach in the analysis about what we ought to fund is also about what's the scope of that. And probably in the discussion that follows, and if I get a chance to rebut, I might talk a little bit about how the scope of what's funded, who's in, who's out, and why also can make a difference in what's ethically relevant or acceptable.
We're going to end round one with Professor Angela Campbell. You've got your icon. I'll let you figure this one out.
I'll be okay. I don't have a PowerPoint. So I tried to be environmental and not print my notes, but then I had a Mac bug. So Carolyn kindly agreed to speak forth. So I'm the last one. I'm okay now. At least my document is okay now. Okay, so thank you for inviting me to the conveners today, and good afternoon to everyone. I'm here to talk a little bit about the legal issues that are raised by the public funding of IVF, according to Quebec's policy and legislative decision in this regard. When you take a look at the legislation, I don't know if people here have looked at the legislation, the statutes and the regulations that surround the decision to publicly fund IVF in Quebec, you'll see that it's highly technical and that most of the provisions relate to things related to things like the licensing of physicians and entities that are entitled to carry out this practice, as well as other factors, for example, related to the way in which the practice is actually carried out. So how many embryos can be transferred at once, et cetera, and that was already touched on by Dr. Dahan. So I would suggest that if you look at the legislation itself, it doesn't give you a good sense of the legal issues that actually could cascade from this policy move. A lot of the discussion around IVF falls more squarely within the domain of economic and social policy than it does within the context of law. But there are a number of legal issues and questions that come out of this decision to publicly fund IVF that have not, I would argue, been carefully considered. And one of the most obvious ones, it seems to me, is the issue of how long you wait for this service. And wait times in Quebec for healthcare treatments of any kind are obviously an issue that are of pressing importance. Someone who waits for an extensive period of time for IVF, who feels that they're waiting too long, doesn't have the entitlement to jump the queue in Quebec by buying the service privately or trying to take out private insurance for this, so they'll wait like everyone else. And that may seem equitable and fair, it's true, but there is also jurisprudence to suggest that something, a weight to that effect that may have an interference with a person's physical or psychological integrity could amount to a constitutional violation of some kind. And that is something to consider. And I would invite us to reflect a little bit on the way in which publicly funded goods do not translate into accessible services and goods. We see this in Quebec with other services. For example, daycare is one, but healthcare is obviously another issue. I would like to talk a little bit also about family issues, which was raised earlier today, but there is a question about whether or not in publicly funding IVF, there is a message that is communicated that we privilege a certain type of family. So is there a sense that we prioritize the family that has a genetic connection? In choosing to fund IVF, there was no concomitant decision, for example, to fund adoption. And adoption is extremely difficult to carry out as a practice. It is legislatively cumbersome. It's difficult to understand how adoption should actually be carried forth in a legal and ethical manner. There are lots of issues, which I will not go into, surrounding international and domestic adoption, but that is obviously another viable way to form a family, and it's linked to the connection of whether or not reproduction is a right or a privilege, and we obviously won't answer that today. But those are the kinds of questions that I think went unasked and certainly unanswered. Connected to this to some extent is the issue of same-sex families and same-sex couples. So the legislation in place, the language clearly articulates that the target is to deal with infertility. And infertility, we heard earlier this afternoon, is defined as 1 year of trying to conceive naturally, if you want to call it that way, or the old-fashioned way, without success, without conception. So clearly this is targeted at heterosexual couples, usually who are in some kind of conjugal partnership. What is excluded then from the model is a single parent trying to conceive, a same-sex family. There is some information on the Minister's website to suggest that a same-sex couple who is a female couple could use the services and be publicly funded, but that is not necessarily clear from the text of the legislation itself when we're dealing with infertility as the target, as the mischief that the legislation is trying to target. And then with respect to same-sex male couples, clearly there would be a need for a surrogate to carry the embryo, the fetus, and surrogacy in Quebec is not legally recognized. So paid surrogacy is actually criminalized by federal legislation, and Quebec civil code rather does not recognize contracts for surrogacy, and it's the only province in the country of all the provinces and territories that is explicit in its refusal to recognize surrogacy as against public policy. So there's a real move then in Quebec to kind of think about families, but there's an exclusion of certain types of families, I would suggest. Okay, one last point is how we deal with infertility. So is this the right way to deal with infertility? It's a problem solver to some extent. We're treating infertility, or rather treating the consequence of infertility, but are we not asking ourselves why this infertility has occurred? And there's been some discussion about the fact that women are waiting longer to have children, and that has led to some, our last speaker, or second to last speaker, indicated that there's this rhetoric that surrounds mothers, and that can be problematic to some extent because the social perception is that women are waiting a long time, perhaps too long, because they're pursuing and chasing careers, and that's blameworthy behavior. So there's this double-edged sword of women being the victim of infertility, but at the same time being the makers of their own misfortune. And that is actually highly problematic and not been sufficiently wrestled with. Is there a way then to think about avoiding infertility or trying to reduce its prevalence without reverting to some kind of 1950s model of the heteronormative family with women primarily occupying the role of mother and homemaker? Okay, I have other things to say, but I think I'll leave it there, and then we can have some proper time for interactive discussion.
When I began, I didn't do the right thing, which was to thank the organizers of this whole session for inviting us. I now can really thank the organizers of this panel because they couldn't have chosen a better group, a better quintet to address the various issues that are there. They've touched on a lot of them. There's some that I know some of you may still feel that you want to hear more about. So what I'm going to do is give you each, we'll go in the same order, a chance if you want to use your 5 minutes, excuse me, to expand on what you've said, or if you want to pick up something that somebody else has said and address that directly. If you want, unlike Professor Deonandan, make a personal statement about what you feel, that's okay too. We will take both direct and indirect comments, but you'll each get up to 5 minutes. If you don't want to use it, we will just throw it open to the audience, or I'll throw out some questions that I wrote down as notes of things we're not yet spoken about. So we'll start with you.
Thank you. I think there are just a couple medical issues. Yeah, it's better. I think there are a couple medical issues I'd like to clarify. There are lots of great points that were put out today, and a lot of things we're clearly not going to resolve. But in terms of some of the medical issues that came out, just to clarify a couple things. One is that, yes, semen analysis get worse with time, but by far the majority of people we see with male factor, which in Quebec is up to 70% of our patients, are young. Right? They're not at an advanced age. In fact, they are in their 20s and 30s. So don't think that most of the people come to see us for male factor are in their 50s, putting the child at risk for more genetic abnormalities, other things that occur with a male reproducing later in age. In fact, they're at a young age, but they have male factor. Most of the causes of infertility cannot be prevented. Right? Male factor cannot be prevented. It's 70% of our patients here in Quebec. Endometriosis, scarring of the tubes from the uterine lining being outside of the uterine cavity in the belly, cannot be prevented. It is a common cause of infertility. Anovulation, meaning a woman not making eggs, most commonly due to polycystic ovary syndrome, a syndrome affecting 10% of women, whereas a tendency not to ovulate, cannot be affected by many changes that people make. This is a disease that people have. And that will count for, by far, the majority of our patients. Clearly, age factor can, right? If people wait to have a child later in age, that might not be perhaps there when they were younger. But it also is a double-edged sword, as has been presented by several of my colleagues. Because I don't think in our society where clearly time is taken off to do education, other things, they would want to necessarily put pressure on people to start reproducing in their early 20s, which is probably the best time to reproduce. Lastly, I think some of the points that were made about Quebec coverage and same-sex couples were very important. But one thing to understand, they clearly do cover same-sex female couples. In fact, they will cover them for in vitro fertilization, where because we have significant evidence that in a same-sex female couple, the best connection psychologically to the child is if one donates the egg and the other one carries, they will even cover in vitro fertilization for that. But male couples are clearly an issue because surrogacy is not covered. And I think that's a very legitimate issue.
First of all, ooh, can you hear me? I want to thank Dr. Dahan for showing me it changes color. Check that out. How cool is that? Yeah. It's not a mood pen, no. Oh, is it? Oh, nice. So I made 4 points. I'm not sure why I made these points. It came up to me as people were speaking. The first is to reiterate that ultimately this is always a woman's issue, a woman's health issue, because even in cases of male factor, with the exception of a few interventions, Dr. Dahan could correct me on this, even if it's a male factor issue, the woman still has to undergo IVF, even if she's healthy, right? So ultimately it becomes a woman's health issue. Second, I want to reiterate what my colleague over here was saying about the need for research. And as a population scientist, I push hard for surveillance as being the thing that we should invest in at the state level. By surveillance, I mean understanding at the population level what the long-term consequences in terms of health outcomes are for people undergoing a variety of ART therapies, and also for the tracking of gamete donation, sperm and egg donation, to sort of follow those clusters of individuals I talked about earlier. That's something we can do in a real sense for not a lot of money at the state level right now. Third, I want to address a misconception a lot of people have around whether there's a monolith or a singleness around the motivation of individuals seeking this kind of therapy. I think when I speak to the layperson, their first response is, well, why don't they just adopt? I think it's a bit unfair. I think we have to understand that reproduction, first of all, is a powerful human instinct up there with survival. But people have a variety of different motivations. One is to reproduce. Another might be simply to raise something, raise a child to adulthood and have a legacy. That's covered by adoption. Then you have the burgeoning egg market industry globally, where individuals will buy eggs and often buy sperm to create embryos, to implant them in themselves, and to create a child, which essentially is the same as adoption, right? You're having a genetically dissimilar creature that you're purchasing to raise, but the difference is you are incubating that creature yourself. And I apologize for the word creature, but really it's a creature. And so obviously the motivation there is the experience of biological motherhood. There's a whole host of motivations here. There's also the motivation of creating rescue children. What's that? That's if your current child needs a donor of some kind, bone marrow, for example, and you haven't got a typed donor, you can use a technology called PGD, pre-implantation genetic diagnosis, to select an embryo that has that matching and create a child for that purpose. This is a huge field, obviously. There's a huge number of ways you can look at this. Fourth, I want to talk a little bit about whose interests the funding is in, as was brought up by our legal specialist. Obviously, the interests of the infertile, and I want to go over a bit about the interests of the state. I suggested a little bit of that when I was whispering before about these need to produce certain kinds of demographically interesting people. There's always an interest by states in reproduction. In Europe, there's a crisis of a lack of replacement rate, as there is in Quebec, and there are all kinds of think tanks producing papers on the role of assisted reproduction in addressing that shortfall. The RAND Corporation had a big study up 3 years ago that looked at how IVF can fill the shortfall of individuals, but not immigration. See what I'm getting at here? So we accept that there's a shortage of individuals in certain parts of the world, insufficient to maintain our standard of living through taxation, et cetera. And the solution isn't to allow the gates to be open and let the hordes in to work in our industries. The solution is to produce more of our own. That's what I'm trying to get at. There's a case that's not well known in Czechoslovakia in the 80s, before that government fell, of the state trying to encourage otherwise healthy individuals to have IVF babies. Why? Because literature showed that IVF babies were wanted babies, and therefore would be better citizens. Well, they're wanted babies because if you're infertile and trying really hard to have a baby, you going to invest in the born your child. They took the wrong lesson from the epidemiology. Luckily, that government fell before that policy was put into place. But the lesson there, of course, is that there's the interest in the state in getting their fingers in this technology don't always have health at the top of their list. I'll move on now.
Well, I would like to follow up on a few things that were said, but mainly I've got 2 points. One is the importance of research, and actually to give some information on some preliminary results from a study that we're conducting here at McGill with Phyllis Elkovitz here and Carolyn in a team, and also some of the controversies, just to give you a bit more depth. We surveyed over 1,000 people who are undergoing assistive reproductive technology in the Montreal area, and we found that over 50% of these people were not born in Canada, and they come from a variety of backgrounds, and I've got a list here: Pakistani, Persian, Russian, Serbian, Sikh, Tunisian, Maghrebian, Vietnamese, Mayan, Maghrebian, and the list goes on. So I'm telling you this because people coming from very diverse cultures are currently undergoing assistive reproductive technology for a variety of reasons. And this could have implications in terms of psychological support, in terms of social support, in terms of trying to provide resources for people in terms of engaging with services, and then also, if they don't happen to conceive, support afterwards.